So we're at TCT 2019 in San Francisco at the Moscone Center, and I have the privilege of having with me Dr. Kirtane. Dr. Kirtane is Director of the Cardiac Cath Labs at Columbia University Medical Center. Ajay, welcome.
Thanks for having me.
Yeah, sure. So congratulations on the EVOLVE DAPT that was presented at the meeting. And what we want our audience and listeners to learn is more about the study, about the motivation and the background. So if you can just describe to us what was the background and motivation to do the study.
Yeah, I think the key thing is that back 13 years ago, because of scares of late stent thrombosis, the FDA and other societies came together with recommendations to increase the duration of dual antiplatelet therapy to 12 months. And that's fine for many patients, but there are patients that are high bleeding risk and can't necessarily tolerate that. Many physicians struggle with this issue in somebody that's had a PCI and needs a surgery or had a gastrointestinal bleed or something like that. And so with iterations in stent technology, also time and studies that have been done showing that bleeding risk is real and can be a problem for folks, I think the idea was to determine what the minimum duration of DAPT is with current generation DES, and in this case, the Synergy stent.
Yes, I mean, I think that the field has moved toward it. It's fascinating to see how we started off with 12 months and 18 months, and now we're backing down to shorter duration, precisely because of the reasons you've mentioned. So educate us a little bit about the inclusion and the exclusion criteria for the study.
Essentially, these are patients that were identified to be high bleeding risk, and you're not trying to say that you should stop at 3 months in this particular case. What we're saying is that if you have to, is it safe? And what was done, 2,000 patients with high bleeding risk, either age greater than 75 plus a reason that the investigators deemed that the risk of dual antiplatelet therapy outweighed the benefits. Also, patients with chronic anticoagulation, about 30% of the overall subset, and then other things, prior stroke, prior bleeding, things like thrombocytopenia. Those were sort of the inclusion criteria. It's important to mention that patients with myocardial infarction and super complex lesions were excluded because it was a US designed study, and at the time it was designed, the FDA was worried that that might result in complications for patients. So restricted lesion criteria, but high bleeding risk. And after 3 months of DAPT, they were essentially dropped off the P2Y12 inhibitor and continued on aspirin to see what the outcomes would be.
And the aspirin was continued indefinitely, or?
Yeah, in this study, the follow-up duration is 3 to 15 months, so aspirin was continued in the vast majority of patients. And the ischemic outcomes, because what we're really worried about if we do this is, are they going to thrombose their stent? And that's what the clinicians are worried about. And the good news is that only 4 patients out of an overall starting cohort of 2,000, the analysis population is about 1,500, had a stent thrombotic event. So the rate is 0.3% from 3 to 15 months. The rate of death or myocardial infarction also made the primary endpoint. And so I think for the restricted population in the study, we can conclude that the rate of thrombotic events is low.
It's incredible. So thank you for going over the results. I mean, I think stent thrombosis rate of 0.3% is very low, and I think most clinicians would be very comfortable with that rate. How would you put the findings of the study in context to the other study which was also presented at the meeting, which is Twilight, which actually dropped aspirin and continued the other antiplatelet agent, ticagrelor? Do you think we've come to a time where it's going to be pretty much single antiplatelet agent for patients who have high bleeding risk after 3 months?
I think the main thing is, it's a good question, and clinicians are going to struggle with this because there's a lot of studies at this meeting addressing this concept. The problem is that you don't want to overgeneralize, and both studies, both Twilight as well as EVOLVE Short DAPT, patients had to be event-free after tolerating 3 months of dual antiplatelet therapy. And in the case of Twilight, it's aspirin plus ticagrelor, which is more potent than clopidogrel. So we don't want to just overgeneralize and say, look, for all patients we can stop and there's not going to be a problem, because that's not the way we have to be. We have to be thoughtful clinicians. But this study, both studies, just the overall emphasis on de-escalation, not only of duration, but also intensity at this meeting, I think allow people to think, and based upon the risks and benefits for their individual patients, titrate their therapy so as to help their patients.
Sure. So, what are the final takeaways for you, and, not only for patients without anticoagulation, but also for patients with anticoagulation? How does the study change your practice, when you, for example, see a patient without anticoagulation and a patient with anticoagulation? What is your strategy for managing these patients?
I think overall, I'd say the take-home message for people watching is that if you're low bleeding risk overall, then there is still going to be data favoring ischemic efficacy
Sure.
if you extend.
Sure.
But do that not indiscriminately, not because you're going to fear a lawsuit, you're going to fear the thrombosis. Do it because you're doing atherothrombotic prevention for your patient, and recognize that if they bleed, then you may be able to stop.
Yep.
And for the high bleeding risk patient, just recognize that bleeding is important. There are now options with specific stents for shorter durations of DAPT, and that may impact your decision making in terms of what revascularization choice to offer, what stent you may want to choose, and ultimately what duration of DAPT you pick.
Great. Thank you very much.
Thanks so much for having me.
Likewise.